Okay, so I think we're gonna get started now. So, hello everyone. My name is Mara Tui, and I will be your moderator for today's session called Aging with PI. And I'm very excited to welcome Dr. Kobayashi, who will be presenting this topic to you today. There will be time for questions at the end of the presentation, so please submit any questions you have to the presenter in the Q&A section of the platform. In addition, we want to mention that today's session is sponsored by Takeda. We are very grateful for the ongoing support of our education and learning opportunities. And of course, we're very grateful to Dr. Kobayashi for being here presenting with us today. So before we get started, I want to share a little bit about Dr. Kobayashi. He is very well-traveled for sure. So he currently sits on the volunteer faculty at the University of California, Los Angeles, previously serving as full-time faculty at the University of Nebraska and UCLA School of Medicine. Originally from Honolulu, Hawaii, Dr. Kobayashi received his BA MD from the University of Nebraska and MS in cardiovascular physiology from the University of Hawaii. He served his residency and fellowship at the University of Southern California and UCLA, respectively. Over his career, Dr. Kobayashi has published more than 100 papers and has been a visiting professor at U.S. medical schools as well as University in Hanoi and Ho Chi Minh City, Vietnam. He has lectured in Europe, Asia, the Middle East, and Central America. He has testified before the U.S. Congress as well as the state legislatures of Hawaii, Kansas, and Nebraska on important health access issues. Dr. Kobayashi is a passionate teacher and worthy recipient of the Outstanding Volunteer Faculty Award from Quad II, the Physician Advocacy Award from IDF, and he was also presented with the Certificate of Recognition for his outstanding contributions on behalf of the Vietnam Medical Association at their annual meeting in Hanoi. Dr. Kobayashi lists his other passions, dedications, and hobbies being his family, 3 grandchildren, Hawaii, and golf. So at this point, I'm going to turn over this part of the presentation to Dr. Kobayashi, but let's give everyone a warm welcome.
Well, thank you. I think that introduction is longer than my lecture, but if you can go to the first slides, I am very proud of being from Hawaii. So if we can have the first slide.
Yes, 1 second. Let's just pull it up here.
The slide you will see is from from Herb Connie, who is a famous illustrator and painter in Hawaii. And we had the good fortune in high school to go to his house. And I've been an advocate of him ever since.
1 second. We'll get it pulled up here just 1 second.
Okay, so as we get the slides, I'll tell you a little bit about Mr. Connie. He has painted a number of pictures and dating from historical pictures of Hawaii all the way to more contemporary pictures, and has also exhibited throughout the world. So when I've given lectures, I've always used his paintings as background.
Yep, and I got them right here.
Okay, there we are.
Yep.
Okay. So as you can see, we'll be talking about a highly critical issue, and that is aging in primary immune deficiency. As we were taught many years ago, we were taught that pediatric or immunology or immunodeficiency is very rare, and it occurs in babies and children. This is completely wrong, and we'll go on to spend the rest of the lecture on this. Next slide. Just a little bit of disclosure. I'm a country doctor from Nebraska. You can see my grandson. He's 1 year old. Now he's 16, and what he tells me is, "Grandpa, I want your car. Why don't you get a new car so I can get you a new car?" So next slide.
Sorry, 1 second here. The slides are getting a little.
I wonder if we can, maybe we can share screen. That would have been easier. And I could change slides otherwise.
Yeah, 1 second. If you could keep going. One
Okay.
second. Have a little technical difficulties, but we'll resolve it.
Sorry about that. Yeah, we normally would have shared slides, and I would have shared slides and then control the panel. But we had a little technical difficulty. And so we're having the monitor or the moderator shares change slides. So in the meanwhile, I think we'll go over some of the things. Number one, primary immune deficiency is not rare. It is very common, as it's been shown. And number two, as we get older, our immune system deteriorates, and as a result, we have more infections. We have more autoimmune and autoinflammatory diseases such as arthritis, inflammatory lung disease, which is a huge problem. And what I'll go on to show you in the slides is that actually immune deficiency, and particularly antibody immune deficiency, is much more common in the older adult than it is in young babies and children. And this was a surprise for us. When we were looking at our data, I follow about 340 immune deficient patients. Number one, as we followed them over the years, and I've been an immunologist for about 40 years, many of the patients grew up with us. And much to my amazement, we found out that in terms of patients, out of the 340 or so patients we were following, we found out that more than 80 patients out of the 310 to 320 patients that we were following were over the age of 65. The other thing we found out was that the vast majority of them were women. And what the Italians and others have shown is that these patients were diagnosed at the average age of about 40. Most of them were women. And as they got older, they developed more complications. So now that we have the slides and hopefully we can advance, let me just quickly go over some of the biases that I have. Now, most of the attention have been focused on young children and genetics. And what I'm saying is that I'm not criticizing what has been done. I greatly appreciate what has been done and the strides we have made for the aged in terms of their needs. But I'm arguing that in terms of primary immune deficiency in the elderly, which is far more common than we ever anticipated, we need to marshal our resources and do much more. I would argue, and I think now the Europeans and others have recognized, that geriatric PID is vastly under-recognized, underappreciated, and constitutes a unique subpopulation which has unique needs. And these needs are not only medical and complications of medical problems, but also interacting with our very complex healthcare, including our insurance system and our fragmented subspecialty and specialty organization. This group has many concomitant diseases, which are problems in themselves, but when you combine them with primary immune deficiency, they are much more difficult to manage. And I would argue that our healthcare system in the United States is extremely fragmented, very difficult to interact. Even if you are the most sophisticated computer person, you would have a difficult time. And imagine for older people. The other thing that the elderly have is we have diminished an aging immune system, which doesn't function as well, and we'll discuss this in greater detail. The ability of the elderly to self-manage is grossly overestimated. Many of the doctors and people who take care of us don't know who the caregivers are, whether we need assistance, whether we can self-treat a lot of the things that we're required to do now. These are issues, and I'm a pediatrician, and yet as we age, we appreciated that we are having a much older population and they're developing more and more needs. And in many instances, our healthcare system is configured towards the convenience of the providers, the hospitals, the medical industry, the insurance industry, the technology, and far less for the patient, even like myself. I mean, now when I interact with the doctor, and I hardly go to doctors, which is, I guess, a no-no. I mean, everything is done by smartphone. And so if you are not savvy with smartphone or computer technology, you have a great problem. And so when I was growing up, President Kennedy was a great hero of mine. And he said, ask not what your country can do for you, ask what you can do for your country. I would paraphrase that, ask not what the elderly can do for you. And I'm talking to the healthcare system, insurance, and government, but ask what you can do for the elderly. Next slide. Okay, there are two huge issues. And on the left, you see the picture of a squirrel. I decided not to put the blind squirrel. What we're saying is that number one issue is not appreciating that primary immunodeficiency is not rare. It is not rare. It is common. It is compounded by coexisting diseases such as heart disease. So don't be like a blind squirrel, and hopefully I'm talking to the government and the healthcare system. Let's not be like the blind squirrel and hopefully think we'll hit upon an acorn. We need to open our eyes and recognize that number one, immune deficiency is common in adults, and number two, it is not rare in the elderly. And as more elderly survive and we diagnose it more, it'll become more of a problem. The second issue is not appreciating the unique characteristics, barriers to care, and also barriers to treatment, the demographic needs of the geriatric patients. Geriatric patients are unique and need a nuanced approach. And I've given about 3 or 4 lectures on geriatric issues in primary immune deficiency and monitoring. And here's one of the references, and there are other references on the IDF website. Next slide. Okay, so again, I'm repeating myself, but I have to repeat myself because we forget over and over and over. Primary immune deficiency is not rare in the immune deficiency group. And here's one of the lectures that we gave for the IDF as a reference. The immune system, like the rest of our organ system, deteriorates over age. In other words, it wears down. Our ability of our immune system diminishes. And as a result of this impaired function, we have more problems with autoimmune disease. We have more problems controlling inflammation, which gets us into problems. Our immune surveillance, in other words, our ability to monitor for cancer, for abnormal cells, to repair ourselves, are all impaired and become health issues. And just like the old car, our immune system wears out, doesn't work well, parts break down, the steering and brakes aren't as reliable, and as a consequence, we have more problems. So here we are at the top, brand new shiny BMW, and I'm not a speaker for BMW, I just happened to find that slide. And then at the bottom, look at us now. I mean, our windshield are wiped so we can't see where we're going. The brakes don't work, the wheels wobble, the steering wheel wobbles, so our immune system doesn't function well, doesn't respond to infections well, doesn't respond to vaccines well, doesn't respond to abnormal cells well, doesn't regulate our immune response well, and as a consequence, we get into a lot of trouble. Next slide. The essential points, and if you walk away with nothing from this lecture, remember these points. Number one, if you have immune deficiency, and the most common one is common variable immunodeficiency or antibody deficiency predominates in adults, complications with primary immunodeficiency increases with age. What that means is that the longer you live, the more problems you'll run into. And in general, the longer you have primary immune deficiency, the more complications will arise. I say this again, more complications will arise, and I'll show you great Italian data. With increasing age, the incidence of cancer increases and is a leading cause of death along with infections. And I want to add on, I want to say that this is a positive lecture and upbeat lecture. I don't want to get you down by saying that there are going to be a lot of problems in the future. There will be, but I'm saying that if we're alert to the fact that we have primary immune deficiency, if we're alert to the fact that there are certain complications that can be run into, if we're alert to the fact that we can diagnose these complications and treat them early, then the lifespan is increased and our quality of life is increased. So monitoring is critical, especially for infections, and we'll talk a little bit about this, cancer and autoimmunity. And the cancers occur in areas where are hard to detect. So if you have cancer of the blood, that's not something that's easy to diagnose unless you have symptoms and go to the doctor. And the same thing with gastrointestinal tumors or cancer. If you had a tumor on your skin or your face, you would know. But if you have cancer of the blood or in the intestinal tract, the symptoms are very subtle and need to be anticipated for. I cannot emphasize that more. Next slide. Okay, the two ends of the spectrum, babies or young children and old people like ourselves. And I'm 76, so although I think I'm 21 sometimes. Two ends of the spectrum, as you can see on the left. In babies and young children, the immune system is immature, and as a result, they get a lot of infections. As you well know, if you have children, kids get infections 6 to 8 times a year. When they get infections, they tend to have more problems, and it's more serious than if you're an adult. They seem to have poor response to vaccines. That's why we give them a number of boosters before the first year of age, and again when they enter school. And because their immune system is not mature, it makes mistakes, and they attack things as harmless as peanut or fish or milk. The flip side of that, and this is why I say it's like two ends of the spectrum. In the elderly, the immune system doesn't work as well also, but it's the result of immunosenescence. That's a fancy word for saying it gets old and it gets worn down and it doesn't function as well. And as a result, we have sort of the same kinds of things as children with exceptions. Number one, we have more infections, susceptibility to infections. But the bad thing about that is that, again, the infections become more severe. And then the symptoms, like if we have pneumonia, normally you would be coughing and having chest pain and all of these kinds of things. Many times in older individuals, they may have an infection, but it doesn't localize. So we don't know that they have an infection. And that's why doctors and patients need to be much more alert for the less adequate typical kinds of response. We have decreased response to tumors, problems with autoimmunity, poor inflammation. And so you can see on the top, I wish I could see the road. On the bottom, how does this damn thing work? And that's just the same thing with our immune system at both ends of the spectrum. Next slide. So again, aging and the immune system, our immune system ages, we have more infections, the problems of comorbid diseases. Nutrition is poor in the adults, oftentimes diabetes, kidney disease, autoimmune disease, cancer treatment, all of these impair the immune system. And if you superimpose all of these comorbid diseases, plus the fact that you get older, and the more you age, the more your immune system deteriorates, even in the non-immunodeficient patient, leads to a difficult situation. Let's go to the next slide because we'll talk about the right side in greater detail. Okay, so immunosenescence, what does that mean? That means that the immune system deteriorates, so there is a decrease in the number of immune cells and they don't function as well. And not only that, the organs that are involved in producing immune cells, the organs that are involved in the maturation of these immune cells deteriorate as well. And as a result, the end product of a highly functional immune system does not occur. The T cells, these are like the quarterback cells of the lymphocytes, and our effector cells, what that means is that they coordinate the immune response, are exhausted and they don't respond as well. The B cells or the B lymphocytes, These are immune cells which produce immunoglobulin and antibodies. They go down in number. They don't respond to a number of new and different kinds of infections, vaccines, or antigens. They don't work as well, and the response is less. So you can see that short-term memory support group, they can't remember why they came. Next slide. Same like our immune system. Next slide. Now, this is a little bit complicated, and I don't want to spend too much time on it, but on the left is a young, healthy individual. So if you can see the top column where it says HSC, what that means is that we have an adequate or an abundance of immune cells that are ready to be programmed to respond to all kinds of different things that we will meet in life. And you have to remember, the immune system is remarkable. I'm Japanese, 4th generation, but if I were programmed for a Japanese response only to those things in Japan, can you imagine the problem I would have if I went to the United States, or I went to Europe, or I went to South America, or I went to Africa, or I went to all these different places where the kinds of infections, the kinds of antigens, the kinds of immune threats are different? So our immune system is able to adapt. And in the young individual that you can see on the top left, that abundance of these cells that can adapt. And the organs that cause them to be able to adapt, like the thymus for the T cells, teaches them how to be mature T cells, and the bone marrow, which produces the B cell, so that they can help fight infection, are again in abundance. And then if you look at our lymph nodes or in the periphery on the left side, the lower end, you can see there's an abundance of these immune cells. It's like a fort and a holding area where infections and all the kinds of things that need to be responded on the periphery, we have abundance of cells. If you look on the right side where we're aged, you can see the lymphocyte cells are very few. So we don't produce as many immune cells as we used to. The organs that produce these immune cells and help them to mature and function don't work as well. And in the periphery, that is like the holding area, the warehouse, the fort, there's not as much of these immune cells. So the response is less and not as effective. Next slide. Okay, again, if you look on the left side, the normal, healthy young adult, abundance of immune cells. If you look on the right side, the number of immune cells go down. We have more inflammatory cells that are not good because they cause inflammation and damage our tissue and cause arthritis and all kinds of other problems. And they don't have the ability to adapt as well, as you can see on the bottom. Next slide. So again, I mean, I'm repeating myself, but I think it's important. The results of an aging immune system. So this is in a normal individual, but superimpose that on somebody who has primary immune deficiency and you multiply the effect. So we have increased infections. We don't do well. Old people don't do well in primary immune deficiency, and old people do even less well. So problems with influenza. The predominance is influenza kills about 90% of people over the age. People who get influenza, 90% of the deaths are in older individuals over 65. Chickenpox is very bad, or varicella and pneumococcus is very bad in the old people. COVID, you have seen the majority, about 90% of individuals who died in the United States were over the age of 65. We have increased malignancy, increased autoimmune disease, and in one study, healthy older adults had far more problems with autoimmune disease, such as arthritis and other issues. Next slide. Okay, so we've been talking about the problems of primary immune deficiency in the aged, in the adult, in the older adult. And our friends and colleagues in Europe have been aware of this because they have a good registries. And here's a study from Europe in the ECID, the European Society for Immunodeficiency, and Bodo Grimbacher and others from Germany published a paper back in 2013 talking about how we manage older individuals. And what they are saying is that, number one, which I said before, it is not just the disease of babies and infants. We have now been able to diagnose adults, and in fact, primary immune deficiency and antibody deficiency, the average age of diagnosis is at age 40. So we're diagnosing them much better than we did in the past. And they're surviving longer. I've had patients that I followed since they were youngsters and teenagers who are now older adults. We have new advances in treating and diagnosing, and therefore they live longer. However, the way we have treated them have been based on how we treated infants and young children and young adults. And what Dr. Grimbacher and others and we ourselves have argued forever is that this older group has unique characteristics, unique needs, and therefore we need research and we need to rethink about how we treat and monitor this older population. Next slide. Okay, so what are the issues? Well, obviously they can't cope with infections. As we've talked about, they have more problems and more problems with inflammatory disease of the lungs. And one of the problems with immunodeficiency is that you don't respond as well, and you may have inappropriate inflammation. And that's why every time you get an infection in your lung, two scenarios can occur. One is that maybe you don't respond well to the infection. The flip side of that is that if you do respond and your immune system is turned on, it may not control it as well, and you may have more inappropriate and prolonged inflammation in the lung and other organs causing problems. The issue of mobility. I mean, older people can't drive, they can't get around as well, they're frail. A lot of them have memory issues, including myself. I hate to take medicines, and sometimes I forget now that I have to take medicines. Their eyesight is not as good, so they might have trouble setting up their subcutaneous gamma globulin infusions. They have hearing loss, social isolation, which is critical. They have a dependence on caregivers, and right now we don't even know, for example, elderly who are doing self-infusion with subcutaneous gamma globulin, do they need help? Are they doing it properly? Do they have a caregiver? Does the caregiver know what to do? And we had a paper where we wrote case studies where, the caregiver was a spouse. And when the spouse had a stroke or died or had some other issue with Alzheimer's, there was nobody to give care to the elderly primary immune deficiency. And these are issues that we don't know about and we have not addressed. And I would argue these are critical issues as we begin to have more of these patients. Coexistent diseases, difficulty in dealing with our fragmented, highly complex, inconvenient, extremely expensive healthcare system. And I say that over and over again. Next slide. Okay, what's the long-term prognosis for seniors with CVID or primary immune deficiency? And again, I want to make it on a positive note that there are problems, there are more problems, there are problems the longer you have the disease. But we can learn more about them, we can anticipate, we can monitor, and we can come up with effective treatment. So the quality of life for the older primary immune deficiency is not a pessimistic one, but one in which we can make better. So it depends on the type of primary immune deficiency, the existence of concomitant illnesses, and most importantly, the presence of non-infectious complications. If you have antibody deficiency alone and just infections, the infections and the use of gamma globulin and other measures help an enormous amount. In fact, antibiotics and immunoglobulin have prolonged life and made the treatment of immunodeficiency spectacular, but not perfect. if you have autoimmune disease and immune dysregulation, then the prognosis is not as favorable. Dr. Cunningham Rondells, in an older paper, older than 10 years, stated that the mortality rate is 11 times higher if you have non-infectious complications. In other words, cancer, autoimmune disease, autoinflammatory disease. In her case study of 411 patients from her practice at Mount Sinai, about 20% died. The median age at death was in their 40s. It has improved over the last decade or so, but it is still problematic. There was a paper that was published in 2021 that stated if you do your remember now we said most adults and older people have antibody deficiency, probably 80 or 90% of the cases, then faithful replacement with gamma globulin is critical in improving outcomes. What does that mean? All of you get tired, bored, and say, why do I have to do this subcutaneous every week or every 2 weeks? And why do I have to do it for months or years? And sometimes when I forget, nothing happens. Well, the thing is that you need to continue to treat on a regular basis. Number one, to prevent infections and inflammation. But number two, studies have shown that if you treat yourselves regularly and faithfully with gamma globulin, your prognosis and your state of health improves. Now we'll talk about the Italian studies, and here I want to spend some time on, because the problem of infection, we've told you, is the leading cause probably of complications and death in primary immune deficiency, but the second leading cause is cancer. And it is critical because it's gastric cancer and intestinal cancers, which are hard to detect until late. And so monitoring and prevention of gastritis and Helicobacter pylori infections, etc., are critical to monitoring. Next slide. Okay, this is a little bit complicated slide, but what this slide shows, and I don't want to spend too much time on it, but it shows that if you look on the top left-hand corner, it shows that number one, in the 455 patients that they had, this is an Italian study of all the patients with CVID, more than half of the patients were 50 years or older. What does that mean? Primary immune deficiency in the older adult is not rare. It's not rare. And in fact, if you look in the age group on the left, between age 66 and 80, there were more patients than in patients 18 years to 35. What that meant was that in the middle age and older individuals, there were more immune deficiency patients with CVID than there were younger patients. And then if you look on the right-hand column, the longer you live, the more complications you have. And also older people have more complications. In other words, the older you are and the longer the follow-up is with primary immunodeficiency, the more likely complications are to develop. So you don't want to be like the third person in the famous saying, what happened? What you want to do is make things happen, and you want to prevent things from happening. And that is prevent complications and anticipate and actively go after them. Next slide. We're almost done. Okay, this is, again, a complicated slide, but if you look on the left side here, you can see much more clearly. If you look at the column on the left, ages 51 to 65 and ages 66 to 80, and you total those are more common than patients who are younger than 50 years of age. What does that mean? In primary immune deficiency, it is more common in the older individuals than it is in the younger individuals. So we got to get away from this thinking. I know it's fashionable to think about all the genetic mutations, et cetera, and all the new diseases that we find leading to genetically based primary immune deficiency. But I would argue that we need to take care of the people that we have diagnosed and the people who are under our care for a long period of time. Next slide, we're going to skip the thing on the left, on the right. The big message is that you have to follow these patients. So especially with gastric cancer or intestinal cancer, you have to do monitoring. Monitor for H. pylori infection, monitor for gastritis, monitor for GI. So you might have to do in primary immune deficiency endoscopy, at least an initial endoscopy to see what the gastric mucosa is like. Do a colonoscopy to make sure you don't have colon cancer. In the case of blood cancers, lymphomas, and those cancers in the old studies were about 10%. In the Italian study, about 8%, which is high. You cannot know you have blood cancer unless you do a test. And so monitoring of the blood tests are very important, and regular monitoring. And also remind your physician that you have primary immune deficiency, that malignancies of the bloodstream may be more common, and that a CBC, a SED rate, CRP, protein electrophoresis should be done. Now, what about technology? Rex Harrison from the My Fair Lady, damn. Internet technology is wonderful. But for older individuals, including myself, sounds like Greek to me. And it's much of our medical care and communication is now internet-based, and it is absolutely difficult. I can tell you, when Nebraska and Omaha tried to set up the shot clinic to give COVID injections, or when COVID first brought out, first of all, the internet went down. Secondly, you couldn't log on. Finally, when you logged on and tried to get an appointment, the appointment was taken, and it would take people hours. And these were highly skilled individuals. Can you imagine the elderly trying to communicate with the healthcare system? If you can't get the doctor's messages, can't get important lab results, what are the consequences? I highly criticize the way we interact with our elderly now in terms of healthcare. It's so Byzantine, so many organizations, so much information, so disorganized. The elderly are at a loss, and it's to their peril. And if you talk to young, highly sophisticated people, even they have a hard time. So we need to make changes in this area. Next slide. Okay, this is a great Hawaiian word, which means put your paddle in and join the effort. So in summarizing, number one, primary immune deficiency is a disease in adults, and it is not rare in the elderly. And the longer you live, the longer you have primary immune deficiency, the more likely complications are to occur. So you need careful monitoring. We need to recognize that geriatric primary immune deficiency is a unique and growing group with special and unique problems. We need to coordinate the care between the doctor, the pharmacy, the nursing services, the infusion services, because they're all fragmented, and every time you change insurance, it changes. We need to have third-party payers ensure that there is coverage and support for care so that we can have caregivers provide the care. We can provide more monitoring for adult, older geriatric patients, and the insurance company recognizing that these individuals have special needs. We need to monitor these patients more carefully. Number one, because they have more complications. Number two, because they cannot interact with the healthcare system as well, but also because they have a chronic, complicated disease in which it requires treatment like subcutaneous gamma globulin on a weekly or biweekly basis. And we need to make sure that it's been done. We need to make sure that they're keeping their appointments. We need to make sure that they're being checked for complications. Research needs to be done in this area to help us better understand how to take care of this. And I have to say the Italian physicians and the Europeans are ahead of us in that area. We need to make sure that the elderly patients are cared for properly. Last couple of slides. Okay, recognize that this occurs, research and accommodate the unique needs of the geriatric immune deficient patients, and ask not what the elderly can do for you, ask what you can do for the elderly. Last slide. I remember when I was growing up as a teenager in Hawaii, and a lot of my friends had older brothers and sisters, and they would do the bop and the twist and the shimmy and all of those. I think the young people forget that ours was a rock and roll generation. So let's keep the idea that I may be old, but I'm still a swinger. Thank you. That's it.
Awesome. Thank you so much, Doctor. A great note to leave off on. Thank you so much for that overview. That was very fascinating. So at this time, we are now have some time available for the Q&A portion of this session. So before we begin, I do want to say that please remember that everyone's treatment and condition are unique. So the information presented during this session is not medical advice or intended to be a substitute for medical advice, diagnosis, or treatment. Always seek the advice of your physician or other health provider with questions concerning a medical condition. So in the chat, we've received some really great questions. And the first question we are going to start off with is for Dr. Kobayashi is, do people with PIDs age at a faster rate than someone with a functioning immune system?
Well, the question is somebody with
I can repeat it. So do people with PI age at a faster rate than someone with a functioning immune system?
Yeah, that's a great question. And I think nobody has really done research on the area. An educated guess would be yes, because you have more inflammation, more uncontrolled inflammation, more infections, etc. But this is an area of research. I would again end on a, I mean, not end, but I would state the positive. We need studies, we need to anticipate, we need to learn the comorbid diseases on primary immune deficiency in the elderly so that we can intervene. I mean, it's just like in Nebraska, just because in the past we had flooding from the rivers doesn't mean we have to accept flooding. What it means is that we can now build dams, we can have weather satellites so we know that a storm is coming, and all these anticipatory things. I would argue that we need to do this in the elderly so that they can live a healthful, happy, and fruitful life. And then you can have your grandson say, hey, Grandpa, I want your car. And then you can have other worries. Your grandson crashing or something. I mean, there are always worries.
Yeah, thank you for that answer. And so our next question is, does aging make immunoglobulin replacement therapy less effective?
Again, that's a great question. Again, these are the kinds of things we need to know. Let me answer it in a different way. If you were a healthy individual, you would make antibodies that work well, and also you would make antibodies to new things. As we age, we don't do it as well, number one. And number two, and most importantly, is people who have primary immune deficiency, especially antibody, do not make enough antibody and they don't work. So what do? We replace it with antibodies by gamma globulin. But you have to remember, the antibodies that we replace are like yesterday's newspaper. In other words, the gamma globulin is a year old. It's gamma globulin from many sources, so it might not be as effective for your location, for your area, or your exposure. Number two, just like when COVID came along, we did not have antibodies to COVID in the gamma globulin that we had. And so, at least to one infection, it was not as effective. So I think the long answer to your question is I think that it is not going to be as effective as we age. And the question needs to be, how less effective? Do we need to give more gamma globulin? In other words, higher levels of gamma globulin to compensate for the older patient? These are questions we don't know.
Yeah, and our next question is, what is the life expectancy for an individual with PI?
Well, again, as we said in the slide, it depends on what kind of PI you have. If you have combined immunodeficiency, the life expectancy is less. Now, fortunately, in older individuals, that form of disease, that is both T and B cells, are less common. It's more common in children, although we're diagnosing more and more of these with genetic mutations, which is beyond the scope of this lecture. If you have antibody deficiency alone and infections without damage to the lung or others, then the prognosis is good. And if you look at Dr. Cunningham-Rundle's and the Italian data, I mean, there are people living into their 80s. However, if you saw Dr. Cunningham-Rundle's data, and it's a little bit, it's 10 years old, but there are new studies coming out on the Italian data. If you have cancer, and I say again, cancer of the blood, lymphomas are about 8 to 10%, 10% in America, 8% in the Italian studies. Or if you have gastric cancer, it's more common in Italian, less common in America because we have more aggressive perhaps in diagnosing. Then if you can prevent these complications, if you can prevent inflammation, and we need to do all these kinds of studies. What are the effects of inflammation or chronic ongoing inflammation? What is the effect of infection and then causing chronic inflammation in the lungs, the liver, the kidneys, and other tissues? Then we can go on and see if we can anticipate and prevent these problems. And then the prognosis, in other words, the lifespan and the quality of life in those individuals will improve. And I'm optimistic. I grew up at a time where we were optimistic. We're from Hawaii, where we crack coconuts and play our ukulele and happy as a clam. And I'm optimistic, but we got to do anticipatory studies. We got to recognize that this is a huge issue and it's going to get bigger. And I would urge all of you to put pressure on the healthcare system to also focus on the older individual.
And then our next question is, what are some diseases that we should monitor for as we age?
Absolutely. We talked about chronic inflammation in the lung, which is critical. Many of these patients may have bronchiectasis. This is damage to the lung with repeated pneumonias. So that is an issue that needs to be monitoring. There are people who suggest that maybe we should get a CT scan on patients who we diagnose to see the baseline of their lungs. Certainly, we should follow their lungs. We should treat aggressively. When I was training, said never use antibiotics in infection unless you can prove you have an infection. In immune deficiency, the contrary, it's the opposite. You got to treat aggressively because you have to assume infection. And a lot of the antibiotics now have anti-inflammatory effects. In fact, the pulmonologists and the ENTs are using antibiotics for its anti-inflammatory properties as well. And so there may be some individuals who need antibiotics frequently or all the time or more aggressively. Number two, we need to monitor for the major complications, and that is we talked about gastric cancer and blood cancer. So we talked about monitoring for lymphoma, non-Hodgkin's lymphoma, Hodgkin's lymphoma, multiple myeloma, and those by blood tests. A CBC, looking for lymphocytes and abnormal lymphocytes. If you have large lymph nodes, if you feel unusually tired, if your organs such as your liver or spleen are enlarged, you should go to the doctor all the time. And also when you go to the doctor, tell them, I have immunodeficiency. I need to be monitored more carefully. I need blood tests to look. And on our patients with immune deficiency, especially the elderly ones, we got blood tests 2 to 3 times a year. And we did protein electrophoresis. And in about a dozen of those patients, we caught a lymphoma or a multiple myeloma. Gastric cancer, if you have gastritis, if you have infection of the stomach, that markedly increases the risk for stomach cancer. Colon cancer is a problem not only in primary immune deficiency, but also in the aging population. And so people should get colonoscopy. And again, we don't know, do people with primary immune deficiency get much more cancer of the colon? Common sense would tell you yes, because their immune surveillance is not as good. Number two, they're more prone to have inflammation in the colon, and therefore with more inflammation, the more possibility of malignant cells, but we don't know. And therefore, monitoring. I mean, like in the old days, you got a map to know where you're going. You didn't drive in LA without knowing where you're going and end up in a place that you're not supposed to end up, or get stuck in a traffic jam. I mean, now we have GPS, so we know, there's a backup, the off ramp at UCLA 405 at the Wilshire off ramp. In the old days, you drove until you got stuck. Those days are gone, and those days are gone in medicine too.
Yeah, and so we do only have about 4 minutes left in the session, so this may be the last question, maybe one or two last questions, but the next one is, should screening for blood cancers be done regularly? And if so, at what frequency?
The question is, do we need to monitor blood cancers?
Yeah, I can repeat it. Should screening for blood cancers be done regularly? And if so, at what frequency?
The answer is absolutely. It should be screened for. Number two, what is the frequency? We don't know. But studies need to be done. We need to have longitudinal studies to see, if you do a CBC and a differential and you follow patients. And the Italians have some of these studies, which you see, and I gave the references. As they follow these patients, they develop lymphomas and develop gastric cancers, etc.
Yeah, and
let me just finish. The older the patient, the more frequently I do the blood test. The more at risk they are, the more I do the blood tests. Do I overdo blood tests? Yes. But like I used to tell my patients, why did you wear your seatbelt when you came to visit me in the clinic when you didn't crash? It means that 1,000 times you wear a seatbelt for the possibility of preventing the one time you might crash. So would you say I ordered too many tests? Possibly. But they're not invasive tests, they're blood tests. And they're not expensive. And if I catch something, great, because then I can send them to the appropriate people and check right away. If I didn't do that, or if I don't follow them, then by the time we diagnose it, it's already spread and a problem.
Great. And at this time, we do only have 1 minute left in the session. So if anyone else has questions that they submitted that they want answered, if you could please submit them to Ask IDF. So just go on our website and send them right in. So at this time, our time together has come to an end. So we want to thank very much Dr. Kobayashi for joining us today. It has been an honor to have you with us. And of note, Dr. Kobayashi elected to decline his honorarium from IDF as a speaker today, and he does so with generosity and gratitude to Dr. Sheldon C. Siegel and Dr. Richard E. Stein of the UCLA School of Medicine. So this session is one of the 39 unique learning opportunities provided through our 2023 PI conference, and we hope you continue tuning in today as we explore other critical topics for the PI community. And thank you again to Dr. Kobayashi and also our partner Takeda for supporting this learning opportunity. So have a wonderful day, everybody.
Thank you again. Bye-bye.